Hello everyone, this is Harshal Desai from Elit's Technomedia Private Limited and eHealth Magazine. I welcome you all to the Radiology and Imaging Summit. We have with us Dr. Mitusha Verma. May I request you, Dr. Verma, to please switch on the camera?
Yeah, sure. Good
Thank
afternoon.
you. Thank you so much, Dr. Mitusha Verma. After the wonderful presentation by Mr. Kamath, we are now uh, going to have a scientific presentation by Dr. Mitusha Verma. She is consultant radiologist at Nanavati Max Super Specialty Hospital. So I welcome you, Dr. Mitusha Verma, and I hand over this virtual dais to you and for the presentation. Thank you.
Thank you for the invitation and introduction. I would just start my screen share, so just let me know if it is visible.
Yes.
So can you see the screen?
Yes, it's very much visible.
Okay,
Yes.
fine. So shall we start?
Yes, yes. Over to you. We are live. Over to you, ma'am. Thank you.
Okay. So good afternoon, everyone, and thank you for giving me this opportunity to be a part of this excellent event. So my talk is a small presentation of 20 minutes on mucormycosis role of diagnostic imaging. So all of us radiologists are aware of this fact that we are facing this epidemic of mucormycosis with the second wave of COVID-19. So this is something like a complication of the second wave of COVID-19 which we came across, and radiologists are playing critical role in identification of this condition as well as in following up with the treatment outcomes. Before we begin, I would like to acknowledge my radiology knowledge to my mentor, Dr. Deepak Patkar sir, and would like to thank all the organizers from ELETS for the successful organization of this wonderful event and for giving me an opportunity to be a part of the same. So the outline of this 15-20 minutes discussion would be an insight into what exactly mucormycosis is, how it spreads into various parts of the body, what are the risk factors, but then we will move to the imaging protocols, recommendations, few case scenarios, and then we'll conclude. So all of us are aware that second wave of COVID-19 started almost in the early part of this year, 2021. uh, Hopefully we thought that COVID would have ended by this, and we had a good news in the form of vaccinations being available, but we had upsurge of cases, and almost zero point 0.4 million or more than that on 7th of May was the highest recorded numbers of cases of COVID-19. With COVID-19 there was something which was relatively new, and it was an epidemic of coronavirus disease associated mucormycosis. So it was almost everywhere in the news, even everywhere on the social media platform and medical journals. But not only this, actually, the hospital and doctors were getting lots and lots of patients who had this manifestation of mucormycosis or invasive fungal infections. And the average fatality rate, which has been recorded with this, is almost 54%, which is quite high. So, mucormycosis is a general term for infection caused by a group of filamentous fungi belonging to the class of glomerulomycosities. So, there are a lot of like genera which are included in this, but the most common one is Rhizopus, and the commonest way it is spreading is that inhalation of the spores, they reach the distal alveolar space or even in the paranasal sinuses, and whenever the fungus gets an adequate environment to grow, they will be like specifically in cases of uncontrolled diabetics, ketoacidosis. This fungus thrives over free iron supportive molecules, and there will be excessive growth and invasion. Many a times it is seen that these fungi are commensal. So that means they are usually present in normal human beings as well. They may be present. But whenever the immunity goes down, it can start proliferating and being invasive. So, what are the signs and symptoms? So, patients presented with varied symptoms in this particular case. Scenarios, the most common being nasal congestion, nasal discharge, which were blackish in color, pain over the cheek areas, so pre-maxillary areas, pre-malar areas, facial pain, numbness, swelling, redness over the face, blackish discoloration over the bridge of nose, palate, and alveolar swelling discharge even at later stages, which were blackish in color. Toothache, this was another spectrum. So loosening of their teeth and toothache was symptoms. Blurred vision, double vision, eye pain, fever, worsening of headaches, mental status change, seizures. So the neurological symptoms were seen at a higher advanced stages of fungal invagination, but earlier the symptoms were more specific towards nasal congestion, facial pain, etc. But it was seen that most of these patients had a history of COVID infection, COVID 19, maybe around 15-20 days prior to this particular manifestation of mucormycosis. They had uncontrolled diabetes, even had ketoacidosis episodes. They were on some form of steroids for long term usage. They were immunocompromised many a times because of post transplant status, neutropenics, trauma, burn. Whenever the immunity, as we know, the high risk factors were all the ones which were reducing the immune status or immunity of a person. Even like malignant hematologic disorders, patients on hemodialysis. But there were young patients as well who were not having a lot of comorbidities, but one common factor is uncontrolled diabetes. So, post COVID patients with immunosuppressive drugs like steroid being used and uncontrolled diabetes together was the commonest. The pathophysiology, which has been brought about in various literature, which we can see, there are multitude, but the most common is that with the immune compromised status and COVID 19 background, acute hyperglycemic state is induced and a state of diabetic ketoacidosis is induced. So, this metabolic acidosis and increased levels of intracellular free iron, that is something which relates to the invasiveness and excessive growth of this opportunistic fungus. And that fungus is known to be angio-invasive, so it is going to invade the blood vessels and then compromise the tissue from its blood supply, causing necrosis. So this spectrum of mucormycosis is going to invade paranasal sinuses, the most common site, mucosa, in high risk patients. With angio invasion, that is by invading the blood vessel, will cause infarction and the tissue to get necrosed slowly, and it can also involve larger vessels leading to complications like infarcts. So involvement could be into the paranasal sinuses, that is called as rhinal or rhinosinusitis. It can go into the orbits, it can go into the brains, that we are going to see what are the ways and pathways of spread. It can also be manifested as pulmonary mucormycosis or cutaneous mucormycosis. So, coming to the role and the way imaging can contribute to this diagnosis of this condition and to follow up this condition after treatment starts. Even IRI, ICRI, that is Indian Radiological and Imaging Association and Indian College of Radiology, has come up with adequate guidelines and updated recommendations of the imaging part, that what all imaging protocols should be followed and what are the critical things we need to report. These are quite comprehensive guidelines and all of us should refer to these. So role of imaging is early diagnosis, because early diagnosis is the key to successful treatment outcomes. Assessment of disease extent. This is very important in cases of mucormycosis because this is invasive fungus, so that we have to determine what extent of invasiveness the patient has acquired at the time of presentation. Then to plan the surgery, so adequately it's going to be a teamwork. So we have to give it information to them so that they can plan the debridement as much as possible and follow up after evaluation, because it may take a lot of times, like maybe 4 to 6 weeks for the areas to regress in size, and the patient will be on long term antifungals. So, one thing to remember is that the disease diagnosis and management is completely a teamwork. So, in these cases, you have to be in loop or in as a part of the team, where it will be the radiologist, physician, ENT surgeons, ophthalmologist, the oral and maxillofacial surgeons, intensivists, neurosurgeons, microbiologists, pathologists. Everybody will have their important parts to be played, and we have to be keeping everyone in loop as well. So whatever your information is, the information on your scans, you have to convey it clearly and also as soon as possible to the concerned treating doctors. So most of the time we have seen that our place, it is practice that we inform them the report, the findings, and they themselves come to the MRI console or CT console to see the scan. So that is how the treatment exactly has to be planned. Imaging in mucormycosis, the two tools which we are using is CT scans and the second one is MRI. Both the scans preferably with contrast. So we will see which one is preferred over the other. CT scans are easily available, relatively less expensive and faster scans. The protocol which you have to follow is that routine CT brain paranasal sinus protocol, but you have to make a point that whenever possible, give contrast, take thin sections, acquisitions so that you can create multiplanar reconstructions afterwards. And you should cover the complete paranasal sinuses, the frontal sinus, cavernous sinuses included. Cover the jaw areas as well, hard palate, cover the mandible, maxillary bone as much as possible, anteriorly cover the ala of the nose and brain to be included in all these situations. CT scans will show us hyperdense soft tissue in the paranasal sinuses. It will be ISO 2 hyperdense, retroantral and facial orbital fat stranding. Bones may show rarefactions and erosions or permeative restrictions. Turbinate hypertrophy, inflammatory fluid in the nasal cavity. We can also document nasal septal perforation, heterogeneously enhancing abscesses may be found, or even intracranial extension. So, this is all what you can offer from a CT scan. What is important to note is you have to do optimal windowing. It's not that only one window will be sufficient to give all the information. One has to optimally window it to see the soft tissue, to see the bone window for seeing the bony erosions. So these are few examples of the CT findings with mucormycosis. So we see that how there is opacification of the right maxillary sinus, and we can see some hyperdense content within. So fungal inspeciated secretions and fungal molecules are known to be hyperdense. So this is an indirect indication of presence of fungal sinusitis. Then here is another example. We see the bone window and we see the soft tissue window, where we can see that there is intraorbital extension. The soft tissue is seen extending into the extraconal as well as the intraconal compartment of the right orbit. But there are a lot of limitations when we compare CT scan with the MR scans. One is low spatial resolution. The amount of soft tissue details which we can acquire with MR is far beyond what CT can offer. Next is limited assessment of intracranial disease extension. So all of us know that the brain parenchymal abnormality and the meningeal abnormalities can be better picked up with MRI and MRI with contrast. Marrow changes are earlier to happen as signal intensity change on MR, and later on will be followed up with erosions. So MR will pick up things much earlier as compared to CT. And here we are looking at something which is invasive. So time is very critical. So as early as we can diagnose and as fast we can provide the information, the outcomes are going to be better. Enhancement pattern is more evident with MR as compared to the CTs. So now coming to the imaging modality of choice, MRI, the protocol which we follow is to cover the brain and to cover the paranasal sinuses, covering the orbit, infratemporal fossa, and at least you have to cover the maxillary bone and the jaw, and so upper alveolus and the lower alveolus if possible. But upper alveolus has to be a part of the scan. So diffusion, SWAN, which is a gradient image, and susceptibility weighted images. T2 weighted images will be acquired in multiple planes, but basic one at least axials. Then you have to acquire a 3D, if possible, a 3D sequence for orbit, otherwise stir sequence or fat set sequence for the orbit, paranasal sinus, and cover the cavernous sinus with high resolution coronal stir as well. Post contrast T1, weighted images will be acquired in multiple planes. If one, then the most important will be a coronal T1 post contrast, which will cover the orbit, paranasal sinuses, and the cavernous sinus. Then an axial T1 covering the entire brain. Then you have to have a coronal flare just to make sure that you cover the brain completely. And also, if required, with certain complications, you might have to add on a few sequences like angio. So basically, what we are looking on MRI are T2 hyperintense or stir hyperintense areas of mucosal thickening involving the paranasal sinuses, which will have presence of interspersed hypointensities within, which will be showing blooming on gradient on sworn images. And when you give contrast, we are going to see that these areas will have patchy non-enhancement within, which is a characteristic feature of angio-invasive fungal infection and resultant necrosis. So there is a typical black turbinate sign, which we are going to see with examples. This only concept behind this is that the tissues are not picking up contrast because of necrosis and they are non-enhancing in signal change intensities. Enhancement pattern will be variable. Even diffusion will help us pick up abnormality. Intraorbital restricted diffusion in the paranasal sinuses and optic nerves also have been documented. So the same thing which we have discussed, showing with few images on MRI. So this is a coronal stir image obtained where you see the paranasal sinuses and you are seeing that there is a lot of mucosal thickening involving the ethmoid air cells and the turbinates. This is not homogeneously hyperintense on T2, but a lot of hypointensity is seen interspersed. And this is the left orbit where the fat is completely normal, and this is the right orbit which we can evidently see that there is a lot of fat stranding and obvious infiltration into the orbit. So in this case, there is a very obvious invasion into the orbital contents, and this is on imaging also very typical for invasive fungal sinusitis when you have a background of clinical history which is high risk factor for the same. See the same thing on axial T2, which is specifically done to see the orbits in high resolution. And here you see that complete end ophthalmitis picture has set in, where the shape of the eyeball also has got deformed. Lot of fat stranding is seen in the intraorbital contents, including the intraconal compartment. Not only this, there is an area of altered signal intensity in the temporal brain parenchyma, which is predominantly iso or hyperintense with small areas of abscess formation as well. This on swan on gradient may show presence of areas of small bloomings within. There could be some metabolites of the fungal infections, or it can be sometimes hemorrhagic contents as well. And this is what we see on contrast, where we see that normal tissue has, or normal mucosal thickening which we see with sinusitis, the mucosa is smooth and enhancing on post contrast evaluation, but in this cases the mucosa here is showing non enhancement. So this is what is called as the black turbinate sign, so where the turbinates are not showing post contrast enhancement. Even the orbital contents, here the extraocular muscles are showing normal enhancement, and here you are seeing that there is no enhancement in the muscles as well. The area is of altered signal intensity seen extending into the infratemporal fossa. So this disease is invasive. So as a radiologist, you have to give a complete picture of the extent of involvement, whether it is confined to the paranasal sinuses or has it gone into the orbits or nearby areas. So let us see the pathways of spread and what are the areas which we should carefully look for. So in short, to summarize, we can see that the areas are close to the paranasal sinuses. So it can extend into the orbit. So most of the time it will start from the medial aspect of the orbit. So the fat which is medial to the medial rectus should be well preserved, and that you can pick up on your normal pre-contrast non-fat sat T1 weighted images where the fat can be easily seen. Then there will be extension seen into the maxillary bone. So palatine process of the maxillary bone going inferiorly involving the hard palate, reaching up to the root of the tooth. So that is the cause of loosening or pain in the dental area. Then you have involvement of the intracranial content, so it can extend intracranially as well, most commonly into the frontal brain parenchyma and into the temporal regions. Then is extension into the cavernous sinus. So here again showing the pathways of spread. It can extend inferiorly into the infratemporal fossa. So the areas which will be showing changes will be like the lateral pterygoid muscles in the region of pterygomaxillary fossa, pterygopalatine fossa, and in the masseter space. So all these areas you have to comment upon and see carefully. The complications which are associated are orbital cellulitis, orbital nerve involvement, neuritis, retroorbital stranding, and endophthalmitis in severe cases. Intracranially, it can cause cerebritis, cerebral abscess, hemorrhages, meningeal or cranial nerve involvement. Vascular complications could be cavernous sinus thrombosis. Intracranial vessels may also get thrombosed, infarcts, which are associated with vasculitis, mycotic aneurysm, which can rupture and cause subarachnoid hemorrhages. Then the inferior extension into the jaw pterygoid fossa can again cause features of skull base osteomyelitis and local abscess formations. So few more cases, but all of them will show similar findings in different extents and spectrum. So here is another case where we see the non-enhancing area, infratemporal fossa showing asymmetric increased enhancement and small patchy areas of non-enhancement. Even intracranial extension is clearly seen. This was a case where the patient came for a routine spine MRI for cervical spine MRI backache complaints, and the patient was diabetic, had history of COVID-19 in recent past, and what we picked up was mucosal thickening in the paranasal sinuses, which was little hypointense on T2. So this just came in the localizer sequence, and when we did a complete paranasal sinus scan, we could actually see these hypointense linear zigzag areas within the maxillary sinus. It was very early pickup. The disease was into the paranasal sinuses only, and it was on histopathology confirmed to be mucormycosis along with aspergillus into it. So no orbital extension, but very early we could on MRI pick up this invasive fungal sinusitis. So similarly, we had almost like every day when the cases were at the search, every day at least one patient we were seeing with different stages of extension. Some were having severe complications in the form of endophthalmitis, in the form of cerebral extension. This is an example where is a sagittal image stir which is showing there is involvement of the hard palate area, and the small abscess have formed in the palatine process of the maxillary bone. Another example, significant orbital involvement, and the patient had to underwent exentration of the orbit because the disease had spread inside, and there was intracranial extension through the cribriform plate into the frontal bone, frontal parenchyma. So here you can see the restricted diffusion evolving cerebritis and abscess, and restricted diffusion with endophthalmitis in the orbit. So these were some cases where we could explain the complications, and there were variety of complications depending on the extent of invasion by the fungus. So extensive areas of infarcts were seen secondary to vasculitis and vasculitic involvement of the middle cerebral artery and sometime even the ICAs. Here is a case where there is extension inferiorly into the palatine process of the maxillary bone, and you can see that the contents here are relatively hypointense as compared to the sinus content, which are showing non-enhancement centrally, and this came out to be again mucor. So another zoomed out image of the same patient. This came as an odd presentation where the patient had all the features of paranasal sinus involvement by mucor and also in involvement of the orbits. But what was odd that this patient presented with subarachnoid hemorrhage, extensive subarachnoid hemorrhage with intraventricular extension. Intraventricular hemorrhage was also seen. So it was postulated that it was associated with mucormycosis and mycotic aneurysms, which ruptured and led to this SAH. This patient was followed up and is right now little stable, has shifted from ICU to normal wards, and is on complete therapy with medical management and follow-up. So these were the infarcts which were also seen in this patient. Another zoomed out image showing the intraventricular hemorrhage and subarachnoid hemorrhage in patient with mucormycosis. Not only there is involvement of the paranasal sinuses, but we have to be aware that it could be pulmonary manifestations and pulmonary involvement as well. So make a point at least to image the chest ones of these patients by a radiograph or preferably by CT scans. We have seen a lot of COVID-19 patient also with superadded fungal and superadded bacterial infections in the chest. So typical reverse halo kind of appearance is seen on the lungs, lung window settings of CT. I'm not going into the details of the chest findings, but just to remember that disease manifestation include this spectrum. So there is a very good checklist which has been provided by IRI, ICRI for mucormycosis patients, and we all should make a point to go through this. And when you are reporting, you can also opt for using this checklist as a part of your report. It is a good summarization of what we saw. So involvement of sinuses, involvement of orbits, intracranial involvement, and all sorts of complications like cavernous sinus thrombosis, arterial thrombosis, subarachnoid hemorrhages, etc. So, with this, I would like to conclude and just to emphasize that imaging plays critical role in early detection and determination of disease extent. MRI with contrast is imaging modality of choice. If CT is the only possibility to be done, we can go ahead and perform a CT with contrast. Early detection is the key to best treatment outcomes, and this is a teamwork to treat these patients where our ENT surgeons, ophthalmologists, neurosurgeons, microbiologists, intensivists, physicians, and radiologists play critical role. So, with this, I would like to thank you all for the patient listening. And if there are any queries, I would like to discuss.
Thank you, Dr. Mitusha. That was indeed a wonderful presentation that you gave, and I hope the audience took good notice of it. And there is a small token of gratitude which we like to present. I would request our backend team to present the certificate.
Thank you once again to the organizers.
Thank you, Dr. Mitusha. Thank you very much, ma'am. See you.